Good morning, ladies and gentlemen. Thank you for joining us today. I'm Dr. Tham. Please allow me the opportunity to share with you some information about cardiovascular heart disease and its treatment. My title will be To Bypass or to Cross. Before we begin, let us take a moment to appreciate this vital organ. This is the heart. Look at the way it beats, in synchrony. It is the source of life. One cardiac surgical trainee once described the heart as a beautiful muscle. When the electrical signal is initiated, it sends the signal across the heart. The heart beats. This is the very first diagnosis of life, which starts in the womb, where the doctor records the first heart sound using the ultrasound. A life begins. The electrical signal captured on an ECG is like the note on a music sheet, marking the impulses of life. However, the heart can get sick. Coronary artery disease and its treatment are one of the most researched and published subjects in the medical world. The world never looked back ever since we recognized the disease, and efforts have been made to treat it. The pathophysiology of coronary artery disease stems from the disease process called atherosclerosis, where cholesterol plaques slowly accumulate on the wall of the vessel, rendering it narrower and narrower. And when it reaches a critical stage, the supply of blood could not meet the demand of the heart muscle. Symptoms occurs. And when the plaque is unstable, it ruptures, clot forms, and the artery suddenly blocks off. That's a heart attack. Listed here are the common risk factors that could predispose you to the development of coronary artery disease, such as habitual smoking, unhealthy diet, hypertension, hypercholesterolemia, diabetes, metabolic syndromes such as obesity, family histories of heart disease, kidney diseases, and others. This disease can kill. In fact, it claims more than 18 million lives every year, positioning itself as the number one killer in the world. So much more than all cancer deaths combined. The good news is the total number of deaths has been in steady decline over the years, thanks to several advancements in medical treatment and intervention. Coronary angiogram made the diagnosis of coronary artery disease possible start from the 1958 to the eventual development of coronary angioplasty in 1977. In 1969, Dr. Favaloro described CABG, which is coronary artery bypass grafting. Then in the 70s and 80s, we witnessed several landmark studies that shows that patients who receive coronary artery bypass grafting enjoys longer symptom-free period and survival when compared to patients who receive only medical therapy. The management of the disease could start in two different ways. First, a patient could present themselves to the doctor with symptoms. Or number two, health screening program pick up patient at risk and get them to see a doctor. A diagnosis will soon arrive and you will see a particular specialist for the treatment of your disease. While the symptoms of heart attack include chest discomfort or pain, some may describe it as heaviness felt in the center of the chest, or jaw pain, shoulder pain, sweatiness, or shortness of breath. But it could also start insidiously as you only feel lightheadedness, easily fatigued, or reduced effort tolerance, or inability to lie flat. All these symptoms are red light, warning signs that your body sent to you. telling you to get it checked. How do we arrive at the diagnosis of coronary artery disease? ECGs and chest X-ray could provide us with some hint. Stress tests can be ordered to rule out ischemic heart disease. However, it is the eventual gold standard of performing an invasive coronary angiogram that will definitively confirm the disease. Echocardiogram can be ordered to look at the heart functions and whether you have any associated valvular heart disease. There are several types of coronary artery disease. It could be divided into 3 vessels or 2 vessel disease, a single vessel disease, or a left main coronary artery disease. Once the diagnosis is made, the treatment starts from the patients accepting the diagnosis, recognizing that this is a highly treatable disease. First and foremost will be the non-invasive route, medical therapy and lifestyle modifications. First and foremost, if you are an active smoker, stop smoking right now. It has literally no health benefit whatsoever. Worst habit a person could have, you are literally burning away your health and money. Next, start eating healthier. We are indeed what we eat. Following that, take guideline-directed medications prescribed by your doctor to control hypertension, dyslipidemia, and diabetes. As for metabolic syndromes such as overweight and obesity, start losing weight by doing exercise. By simply taking medicine, it could reduce your risk of getting heart attack. It could also reduce your risk of going through invasive procedure. However, is conservative treatment enough? If you have recent events such as heart attack, remain symptomatic despite optimal medical therapy, or have the diagnosis of triple vessel disease or left main disease, chances are you will need intervention. Here we are. Should we choose to cross or choose to bypass? If smoking is the worst invention, then drug-eluting stent could perhaps be one of the best inventions of the 20th century. This less invasive technique uses principles similar to performing an angiogram. An interventionist skillfully passes a wire through the narrowed or blocked artery. Then he uses a balloon to force it open, and a stent to keep it wide open. Just like that. Like a blocked tunnel, once again seeing light, the heart once again receive more blood flow. However, bypass surgery resupply the heart with more blood flow via extra conduits or blood vessels harvested from other parts of the body. Commonly, the internal mammary arteries, the great saphenous vein from the leg, and radial artery from the hand will be used as conduit to bypass the blocked arteries. The internal mammary artery is made for bypass. It is as if the body knows that we will need help in the future, and evolutionary development made it a superior blood vessels in such close proximity to the heart. This allows the surgeon to use it to bypass the most important blood vessel in the heart, the LAD. This is what made all the difference. The superior long-term patency of internal mammary artery grafted on an LAD is what cemented coronary artery bypass grafting as the ultimate treatment that improves survival. It remains patent and functioning in more than 90% of the time in 10 years. And amazingly, it still works well in 80% of the time in 20 years. Coronary artery bypass grafting wouldn't be possible without the advancement and increasing safety profile provided by the heart-lung machine. It is the cardiac surgeon's best pal. After general anesthesia, The chest is opened via a median sternotomy approach. All conduits will be harvested simultaneously. Following that, heparin is given to prevent blood clot from forming. The surgeon then connects the body to a heart-lung machine in order to take over the job of the heart and lung and support the rest of the body. Because the very next step of the surgery is to stop the heart. A clamp is applied on the ascending aorta, and after that, cold infusions of cardioplegia solutions will render the heart medically stop. The surgeon then performs his craft of sewing the graft harvested on the coronary artery, which is often less than 2 mm in size. Once the surgery on the heart is completed, a cross clamp is removed and the heart once again receives blood and start to beat again. At the end of the procedure, the machine will be separated from the body and the patient will be transferred to ICU for further monitoring. All these methodical and skillfully executed steps is akin to performance of a symphony orchestra, with the conductor being the surgeons, aided by various specialists of different musical instruments. The performance is carried out in a well-lit theatre. For your heart, this is a scene of typical cardiac surgery, where every trained specialist, surgeons, anesthetists, scrub nurses, perfusionists, OT attendant that kept the OT sterile and clean, these people are instrumental to the success of a surgery. When we discuss about coronary artery bypass grafting, we can't run away from listing stroke and death as the two most significant risks arising from this mode of treatment. In fact, the average risk of 1 to 2% for death and stroke is significantly higher than that of ballooning and stenting in the first year of treatment. However, these risks slowly become insignificant when compared to PCI in 3 years. It is then, for a patient that survives, he or she starts to enjoy the benefit from bypass surgery, which are improved symptoms, improved quality of life measured from the reduced need for repeat revascularizations, and of course, improved survival. This graph displayed shows the average death rate in National Heart Centre of 1.4% for patients going through isolated coronary artery bypass surgery. These slides highlight the 3 different aspects when weighing treatment options. First, what's their risks and benefits? Which options offers better long-term durability? As for survival, are you after a short-term survival or a long-term survival? While there are several important patient and disease factors that determines which treatment is more suitable for you, PCI is often described as a fast and quick procedure, just like the sport sprinting. It often carries lower risk, shorter recovery period. However, just like sprinting, the journey it offers is shorter. The chances of recurring symptoms are higher, especially for patients with 3-vessel disease and patients with diabetes mellitus. Coronary artery bypass grafting, on the other hand, is like running a marathon. It involves longer hospital stay because of longer recovery period. It carries higher risk, but you get to run longer. You tend to live longer and enjoy longer symptom-free interval. In short, it is the more durable option. If you are still confused, don't worry, we are here to guide you. Talk to your cardiologist or cardiac surgeons. Start engaging in these life-changing conversations and discussion of how to improve your life. As the management nowadays are more patient-centric, so that each patient could make an informed and responsible decisions for their life. After all, we as doctors wish to see you on a fine evening while sitting in a cafe ordering a cup of coffee. We will see you across the table with your loved ones. You need not say anything to me, nor me to you, but we both know you made it. In summary, I hope you are able to answer these few questions. Are you aware of your risk? Do you need treatment? And how much do you know about your treatment options? And which treatment options to choose? When do you cross? And when do you bypass? But before I end, I would like to say that I'm not here to preach about coronary artery bypass grafting. But please humor me. Try to draw a line on the screen in front of you on this beating heart, along the surface of the coronary artery. If you think this is almost impossible, next we have Dr. Chua, who will be telling you how he cradles the beating heart and performs surgery on it via a small hole. Thank you for all your time and attention.